Okay, it's been loaded. I want to first thank Dr. Devdasan and his colleagues for inviting me for this meeting. The topic that was assigned to me was issues related to health services delivery for universal health care. I just want to quickly connect to the morning session because I think some of the questions and some of the formulations that were made in the morning session is something my presentation will speak to. Firstly, I would like to highlight what Dr. Ann Mills made in her presentation, which is going beyond description of structures, but really asking some very important and difficult questions about how institutions behave and think, and do we imagine health institutions to do that? The second set of issues was also flagged by a practitioner, Girija Vaidyanathan, where she talked about the kind of constraints they face when a program is rolled out and what are the possibilities for universal health care. So I think we had, and then of course we had Dr. Geeta Sen, who presented the financing aspect of HLEG, which I'm not going into in this presentation. So with these few remarks, I'll just go straight into my presentation, and Siddharth, please warn me when I am 5 minutes before my time. Firstly, I'm going to state a lot of the obvious that we know. One, that what are the characteristics of the health service delivery? In India, you have multiple actors in health service delivery in terms of levels, ownership, and systems of medicine. Second is that we do have a mixed economy, and there was a lot of discussion this morning about it, with a large and growing presence of the for-profit private sector. This is marked by intra and interstate variations, which of course Girija spoke about in the case of Tamil Nadu, which is applicable to all other states as well, in availability, accessibility, quality, and acceptability of services across sectors. And I'm not just talking about the public sector. An idea which I think is very important when we look at health services is to use the concept of stratification in understanding the services in terms of size, scale, and roles. And the idea of Weber, Max Weber's idea of power, and using the lens of power to understand this hierarchy is very, very important. And that we need to understand that this hierarchy of power exists within the public, private, and the non-profit sector, and also cuts across them. So this is an idea which I think is very important when we are looking at access to universal health coverage. Now, the second set of ideas which I want to throw up is that we normally talk about public health system strengthening as if public sector is somehow independent of the private and the non-profit sector. The conceptualization, I think, which is very important if you want to take a systems perspective to universal health coverage, is that you have to look at them as necessarily dependent and interdependent. And I'm not getting into the history and the ways in which these interdependence has grown, but the fact is that you have to, in the Indian context, really be able to formulate it in this fashion. There are many pathways through which these are interrelated, and I just give a few examples, and Girija spoke about it. Private practice by government doctors, private practice not just relegated to individual private practice, but being owners and promoters of nursing homes, diagnostic facilities. So one of the things that the ICSSR and the ICMR committee way back in the 80s commented was that there was actually a blurring of boundaries between the public and the private sectors. And it set me thinking, so what has this resulted in? One, there is an overlap of the roles and functions, and it's also a duplication of roles very often. And very interestingly, there are alliances and conflict within and between the different actors. And I just want to very quickly exemplify this by saying that within the private sector, you have conflicts between the small, medium, and large players, but you also have alliances. And we have evidence to show that, while the IMA on the one hand will argue for banning quacks in rural areas and in urban areas. If you really study them carefully, you find there's a vertical integration that has happened between the quacks and right up to the corporate hospitals. So there is this process of referral that is going on, and how the formal private sector actually uses the informal for patient supply. So you find that there are alliances, but on the other hand, from a professional organization, it's presented as a conflict. So you have many such pathways where you have these kinds of contradictions coming about. Now, the relationship between the government and private sector, in a sense, encompasses all the above. So you do have the public sector itself playing a role, which encourages the private sector. And those of us who have been in public health long enough know the earliest cases of that family planning program, or many of the disease control programs that sought active partnership with NGOs and with the for-profit sector. So you do have these, historically, these alliances that have been made over time. Now, most of us, and I think many people who work in the area of policy and epidemiologists, really look at the number distribution and in the three sectors and try to look at, you know, population bed, population personnel, population institutional kind of analysis. But one of the things I want to bring to this forum is that at a deeper level, an analysis of the dynamics and behavior of institutions within and across sectors, I think, is very, very critical. Now, the policy discourse, if we look at it, really assumes that government is the leader. But I was looking at the recent health policy documents. By recent, I mean the last 5-10 years. You find that the influence, and you have to read the subtext for this, shows the influence of the for-profit sector, both pharmaceutical and medical. So it is not true that somehow health policy or government health policy is only determined and shaped by government, but that there is a very, very critical engagement that is going on of the private sector with policy making. And I look at it at levels of policy making. I look at it at the local level, the state, and the national level. So it is not, we need to take once again a systemic view of how these various actors then play a role in representing, lobbying, shaping public policy. Now, what we also need to understand is the private sector itself represents a plurality of interests, and it has influenced government policy. I'll just give you an illustration. I've taken, when I say private sector, I've included the not-for-profit and the for-profit. For example, the health NGOs, some of them, who have been engaged with health movements, have been raising issues of equity and concerns about equity. Now, at another, in another domain, which is the different levels of the for-profit sector, they're lobbying for public subsidies. They're asking for greater expansion of public health insurance schemes, and also support for cash transfers. So you have, within the private sector, very different motivations, different ideological moorings, if you like, but also putting pressure on policy. So in a sense, when you say government policy is being pulled in many directions, you'll need to understand the dynamics of this. An important aspect which has been, in a sense, ignored in much of the academic writing, as well as in the policy making, is the silent but powerful corporate sector that has consolidated its presence and influence in policy making at the highest level. What is very interesting is the corporate hospitals and the corporate entities in health have, in a sense, bypassed the Ministry of Health. They are now an industry. They do not come within the jurisdiction of the Ministry of Health. So in any debate and dialogue, you will find that the corporates have direct access to the finance ministry. They have direct access to the Prime Minister's office. They also have direct access to the highest levels of the Planning Commission. So at some level, when you look at universal health care and even the debate that's going on today, you find that the corporate sector piece is missing, because the corporates, and in fact Geeta Sen said that this morning when the the chairman of the Planning Commission apparently said that we are not putting the private sector in your terms of reference because the corporates are always putting their case forward to us. So we know what they want. So, it's very interesting that you completely kind of ignore this very powerful, but I say silent because they're not as visible as we imagine. Yeah, I have only one more slide. What is very important also about the corporate sector is in our own imagination, we see them as tertiary care providers located in urban centers. I have actually been doing some work to try and understand how has the corporate sector diversified in the last 5 years. And if you look at Wockhardt, if you look at CARE, if you look at Apollo, if you look at some of these larger enterprises, it's not true for Max, they have actually diversified into secondary, primary level care. They have diversified into setting up pharmacies and diagnostic centers. And these networks are no longer confined to urban metropolis. They have gone into small towns and rural areas. So in a sense, they are what we would call in public health language, they have a fully worked out referral system. They have a network, they have all their pieces of the, the requirements of a full referral system worked out in their own respective networks. And it's also interesting that different companies have portioned or carved out different parts of the country for this formation of the network. Okay, so given these dynamics, what are the challenges for UHC? And I'm going to throw up some provocative questions, and some of these questions were raised by Ann Mills as well in the morning. At the moment, there's too much emphasis on access to curative services. Somewhere this whole issue of comprehensiveness is missed out. Where is the space for preventive care? How do we see the relationship between preventive and curative for effective health care? Those questions remain unanswered. Now, the second set of questions really is, does the private sector have a role in primary level preventive care? The reason I raised this as a question when I was writing these thoughts that came to my head, when the revised National Tuberculosis Program was launched, they did involve private practitioners. They trained private practitioners for case detection, and in some places even for treatment. This was tried for malaria as well. So what happened to all those experiences? We don't know. I mean, it's almost as if we need to really relook at that evidence. The work of Uplekar, for example, in Mumbai, which is of course very region specific and specific to a city, an urban center, shows that the primary level practitioners were quite effective in the tuberculosis program. So what has happened to the, so what about the informal private sector is one set of questions. And then reviewing experiences of contracting with the private sector to assess opportunities and constraints. I think we have a fairly decent amount of evidence today, and in fact, somebody who was talking about public-private partnerships, I think Girija said it was quite a failure in Tamil Nadu. I think we need to look at those, we need to look at contracting in of private sector for CGHS, what a mess we landed in and what happened to costs. So we do have evidence on that. The last two questions are questions which are clearly difficult. But one of the questions I really want to ask is, how public is the public sector in India? The reason I ask this question is, if you have doctors, and this is not something that has happened in the last 10 years. This began in the 60s, it accelerated during the 70s. If you have government doctors and government practitioners diverting patients out of public systems into private sector, how are you then reshaping perceptions of people about the public sector? So, this question of how public is then the public. If you have to pay user fees to get treatment, if you have to pay for your drugs, if you have to pay for your diagnostics with all the contracting in of diagnostic facilities, how public is the public sector? So in a sense, have you thrown the public sector into competition with the private sector much before you're talking about in the UHC? The last question is a question which really interests me a great deal in this, watching this debate on UHC. What is the extent of faith that people like us have in the public sector? And I think it's an important question to ask. And I also feel that's why we are slightly apologetic to say, yes, we can make a public system work. Because middle class is exited, there's enough evidence from studies, the NSSO data, pretty much from the public sector, as was the case in education. The political class today goes for its treatment only to corporate hospitals. The administrators somewhere feel that public systems don't really function, that private sector is slightly better. And that doesn't preclude us academics as well. Thank you.
Thank you, Professor Baru.